We have near 2,000 peer-reviewed publications among us, led by Professor Paul Marik, who's our intellectual leader. We came together early on in the pandemic, and all we have sought is to review the world's literature on every facet of this disease, trying to develop effective protocols. I do not know of any task force that was assigned or compiled to review repurposed drugs in an attempt to treat this disease. Everything has been about novel and or expensive pharmaceutically engineered drugs. We now have 11 randomized controlled trials. Every one of those controlled trials show that in the ivermectin treated group, lives are saved. There's less need for hospitalization. There's less transmission, less case counts. It is a fundamentally and powerfully effective therapy against COVID-19. We need the NIH to review these data. We have the data. If the therapy I have is either low cost, low resource, or extremely safe, and its potential for benefit is high, it would win the risk-benefit analysis, and you should be given it.
I'm an academic doctor. I see patients, but I'm very involved in research. I'm an editor of 2 major journals. I started to survey the literature. I had patients with heart and lung disease who needed urgent treatment, and I refused to let an illness, which lasted for 2 weeks at home, before they got sick enough to be hospitalized, I refused to let a patient languish at home with no treatment and then be hospitalized when it was too late. It was obvious. That was obvious in April that was the case. So I used the best tools or drugs available at the time. We summarized all we knew about the available drugs, and we published our findings in the August 8th issue of the American Journal of Medicine. And the title of that paper was The Pathophysiologic Basis and Rationale for Early Ambulatory Treatment. And I have to tell you, when I was the lead author in that paper, but we had dozens of authors from Italy, India, UCLA, Emory. We had the best institutions in the United States. I can tell you the interesting thing was there was 50,000 papers in the peer-reviewed literature on COVID. Not a single one told a doctor how to treat it. Not a single one. When does that happen? I was absolutely stunned. And when this paper was published in the American Journal of Medicine, it became a lightning rod. Oh my gosh, it became the most cited paper in basically all of medicine at that time. The world started, and boy, the world started knocking on my door. And I had never been on social media before. My daughter, who was home from law school, was talking to her about it. She said, well, why don't you make a YouTube video? So I made a YouTube video with 4 slides from the paper. This is a peer-reviewed paper published in one of the best medical journals in the world. 4 slides. I even wore a tie and a suit, and she showed me how to record it in PowerPoint, and I posted it on YouTube. It went absolutely viral. And within about a week, YouTube said, you violated the terms of the community. And that's when Senator Johnson's office got involved in Washington and said, oh my gosh, this is important scientific information to help patients in the middle of this crisis, and social media is striking it down. Based on what authority? Well, one thing led to another, and I became the lead witness for the U.S. Senate testimony of November 19th, 2020. And the reason why there was Senate testimony is because there was a near total block on any information of treatment to patients. Patients actually think that the virus is untreatable. And so what happens is they go out to get a diagnosis. Now, I'm a COVID survivor. My wife in the galley is a COVID survivor. My father in a nursing home is a COVID survivor. You get handed a diagnostic test. It says, here, you're COVID positive. Go home. Is there any treatment? No. Is there any resources I can call? No. Any referral lines, hotlines? No. Any research hotlines? No.
I am hopeful that we could persuade people to listen to us. In fact, I think that has been one of the things I've regretted through this entire crisis is this attempt to suppress scientific discussion because some ideas are too dangerous to even discuss. I don't think this idea is dangerous. And frankly, I think if you ask me, it's dangerous to do what we're currently doing.
One of the basic principles of public health is that you cannot look only at one disease. You have to look at public health very broadly. The strategy we have used for COVID-19 has not been good for COVID-19, but it's also generated enormous collateral damage on other public health. Less plummeting vaccination rates, less cancer screening, worse outcomes from cardiovascular diseases and mental health problems, and so on.
And that strategy essentially consists of shielding the vulnerable or investing quite seriously in finding ways to protect the vulnerable, those in care homes, obviously, and stopping infections in hospitals, but also more generally in the community. We think we can do that while allowing those who are not vulnerable to this disease to go out there and get infected and build up what we call and will continue to call herd immunity.
Herd immunity is not a strategy. Herd immunity is a fact about most infectious diseases, the course that they spread through the population. Even if we were to have an effective vaccine, we would be relying on herd immunity as the endpoint of this infectious disease epidemic. So it's less of a strategy than a recognition of a biological fact. Our strategy takes advantage of that extra that knowledge we've gained about this and proposes concrete ways of addressing the needs of the vulnerable so that they don't become infected, so they don't die from the disease. While at the same time, the people who are suffering from the collateral damage of the lockdown, closed schools, closed businesses, closed universities, depression, suicidal ideation, all that enormous collateral damage, when they face very little risk from death from the disease, that has to end. So the premise is not to do something reckless. The premise is to take account, as Dr. Kulldorff said, of all of public health. What I see is a scientific consensus among people who've looked at this very carefully. Now, of course, I understand there are people that disagree with us, but I think we can persuade them if they're looking at the same things we're looking at and thinking about the same models we're thinking about, and thinking about the policy and the collateral damage in the way that the evidence has become undeniable and hard to ignore.
Is this almost a more traditional epidemic response that you're proposing? Is there any sense in which this is what you would have expected us to do?
It is. This is basic public health 101.
I remember in mid-March, one of my daughters saying, no, we're going to go into lockdown. And I said, no, that just simply can't happen. The image in my head then was of what lockdown would do. I was thinking, what's going to happen to the person living in the slum in Mumbai? What's going to happen to the person in the township in Cape Town?
The science and the morality point in the same direction, as does standard public health practice. And we're just calling to return to all of those things.
Our response to this has been very myopic, I suppose. Or blinkered. We've been looking down a single axis on this. And that's been my problem right from the outset, is that we surely right from the outset should have started thinking about all the damage that could be done and would be done if we simply went about following this single goal of getting rid of or suppressing this virus.
We've become obsessed with one metric, perhaps.
One metric, one kind of message, one kind of goal, and the language that surrounds it is very sort of bellicose and very directed at the achievement of that goal. And somehow it's sucked everyone in, and it's created this space, a space from which one can, virtue signal madly. If this only gets people to sit up and look around and say, oh my God, 130 million people are going to starve to death as a result of this. Just that one thought I'd like people to keep in their heads.
Dr. Kulldorff?
While everybody can get infected, and many will get infected, the risk of mortality, the risk of death is very, very different across the ages. And it's not like it's twice as high risk. It's not that it's 5 times high risk. It's not that it's 10 times. It's not that it's 100 times. The difference risk between the oldest and the youngest is more than 1,000-fold in terms of mortality. So while everybody can get the disease, everybody can get infected, the risk of mortality is very, very different between the oldest and the youngest. And there's more than 1,000-fold difference in the risk. And that is, in a sense, a weakness of the pandemic. And if you have an enemy, which this pandemic is, we have to utilize that weakness to minimize the death and to minimize the collateral damage to our society.